Hello, KJR. Thank you for giving me this opportunity to present our research, Effects of Expert-Determined Reference Standards in Evaluating the Diagnostic Performance of a Deep Learning Model, in particular on the Malignant Lung Nodule Detection Test on chest radiographs. I am Jung and Ha, a master's student in Math and Statistics at University of Oxford, and this work is done with Professor Hyuk Lee and Chang Park at Seoul National University Hospital. To show the motivation of our research, let's first look at the typical process of evaluating the diagnostic performance. For a given diagnostic task, the radiologists or algorithms can make a diagnosis, and such diagnostic performance is assessed according to the reference standard as shown in this confusion matrix. The result of true or false positivity and negativity is a significant metric in performance assessment. Thus, the rigor of the reference standard is essential for accurate assessment. However, we should note that, due to the unavailability of reference standards, subjective standards based on experts' interpretations are prevalently used as reference standard of AI research. However, in the deep learning models, the measurements may be massively affected by using subjective standards. In particular, medical imaging field is highly human interpretation dependent, often having large intra- or inter-observer variability. And this may cause the bias in the evaluations of AI performances. Hence, the objective of our research is to observe the consequences of using subjective standards in the evaluation of diagnostic performance of deep learning models. Our observations divide largely into two parts. First, we observe the adherence of the subjective standards that we suggest to the reference standard. And next, we examine the impact of the subjective standards for diagnostic performance assessment. The target task of our research is the image-based malignant lung nodule detection from chest radiographs. And for this research, we prepared total 100 chest radiographs of 100 patients, consisting of 50 radiographs with pathology-proven lung cancers and 50 normal ones. As mentioned previously, the research is in twofold. First, we observe the adherence of the subjective standards to the reference standard. The subjective standards that we consider are individual judgment, majority vote, consensus judgment, and the latent class analysis model, which is an LCA model in short. And next, we examine the impact of the subjective standards for diagnostic performance assessment through our reader tests. The reader tests are done by three groups of readers, one with 10 radiologists, one with 10 radiologists assisted by the LAD model, and lastly, a deep learning-based automatic detection model. To discuss with the subjective standards, we should first construct them. So 100 given chest radiographs are labeled by 10 graders from 7 institutions across Korea. According to the box annotations of radiologists, the labels of each radiograph is defined in binary forms. Then the labelings of the 10 graders are aggregated into different subjective standards using different methods as shown. So to elaborate, the subjective standard using individual judgment is as it sounds. The grading of each radiologist becomes the subjective standard. For majority voting, we constructed 4 different majority votes and found the optimal number of voting panels. 2 consensus judgments were made through 2 distinct consensus meetings organized at 2 institutions. Lastly, we constructed a subjective standard using latent class analysis model, which is a statistical model to observe inherent interactive patterns within expert judgment. It estimates the tendencies of individual judgments and conclude which latent class each chest radiograph belongs to. This is a more realistic example. Given many patterns of decisions, LCA model calculates the estimates for positive rating predictive validities for raters respectively and outputs the probability that each pattern of decisions imply positivity. The reader tests are conducted by 10 thoracic radiologists who did not participate in the construction of subjective standards. On the same 100 chest radiographs, the radiologists rated the radiographs without and with the help of a deep learning model, and separately, the deep learning model alone rated the radiographs as well. Then the performances of them are assessed by a reference standard and constructed subjective standards. Now we make the statistical analysis on the adherence of our 5 subjective standards to the reference standards and the performances of readers in the reader test. The analysis is made on 3 metrics: sensitivity, specificity, and accuracy. And those performances are compared using t-test analysis. So now we have our results. For majority votes, the panels with 7 radiologists were chosen to be the representative majority vote panel. This was because, in respect to its adherence to reference standards, 7 reader votes outperforms 5, 3, or 1 reader votes, but has no statistically significant inferiority to 9 reader votes. Now comparing the constructed 5 subjective standards, LCA model is the only standard that outperforms in every metrics. This is the result of the reader tests. Having the ratings of 3 types of readers, their performances are assessed by the reference standard and 5 constructed subjective standards. There are 3 points we can learn from the results. Note that the left figure shows the sensitivities of the reader tests and the right figure shows the specificity. And the red dot shows the performance assessed by reference standard, and the rest shows the performances assessed by our subjective standards. First, there is consistent bias in the performance assessment when subjective standards are used. The sensitivities are overestimated by subjective standards, and the specificities are underestimated by subjective standards. Secondly, we could examine how the addition of DLAD to the radiologists affects such bias from subjective standards. When you see the gap between the red dot and the other dots, the overestimation of sensitivity gets mitigated by the addition of DLAD model, and the underestimation of specificity is exaggerated by the addition of DLAD model. Lastly, the added value of the DLAD model to the radiologists on diagnostic performance is verified in almost all standards. We can see it comparing the gaps between the dots with the same color in these figures. Now let's discuss on the reasons of such results. First, the reason the LCA model was the most adherent to the reference standards can be interpreted by the property of LCA model that it learns the inherent preferences of each expert, so the model could be free from the biased tendencies of the limited number of experts. We can also explain the bias from subjective standards in reader tests. The key of overestimation in sensitivity and underestimation in specificity is in the inherent characteristics of subjective standards. Note the formula of sensitivity and specificity here. High sensitivity implies that it easily gives positive, and high specificity implies that it easily gives negative. Hence, in the reader test, if the subjective standard has high sensitivity, false positive decisions can easily be mistaken as true positives, and true negative decisions can easily be mistaken as false negatives, resulting underestimation in sensitivity and overestimation in specificity. And similarly, the subjective standard with high specificity results in underestimation of specificity and overestimation of sensitivity. Now back to our results. Our subjective standards tends to have low sensitivity and high specificity in adherence analysis so that they more easily yield negative results. Hence, the overestimation in sensitivity and underestimation in specificity is observed. Also, the overestimation of sensitivity could be affected by the fact that the radiologists in the construction of subjective standards and in reader tests share the common characteristics in reading chest radiographs as human beings. For example, both the readers in reader tests and the radiologists who constructed the subjective standards are only detecting clearly visible lung nodules. What is interesting is that this tendency was also observed in the DLAD model, since this model was trained with the labels determined by the radiologists as well. Lastly, for limitations of this research, we should note that the sample size of 100 radiographs was quite small, and also the 10 radiologists participating in the reader test might not represent radiologists in general. Finally, the research is limited to a particular task, malignant pulmonary nodule detection task, so further researches to generalize our results should be expected. Long story short, we can conclude that the LCA model showed the closest adherence to the reference standard in our task, and that the subjective standards led to a bias in measuring the diagnostic performance. Thank you for listening.